Start recording. Okie dokie. So this is the study guide for the midterm. Just looking at the exam itself, there are 200 points for the midterm. It's a total of 86 questions. And then they're kind of split up a little bit in how the questions are. 4 of the questions are fill in the blanks. 4 of the questions are select all that apply, and then there are 4 case studies. So when I talk about case studies, I mean similar like what we did on the last test for hemodynamics, where it kind of gives you a little scenario of your patient, some vital signs, your hemodynamic numbers, and you kind of have to interpret those and come up with your treatment plan. Okay. The case studies, there's 2 hemodynamic ones, which will be very similar to the ones last time. The only additional piece that I put on there was interpret your vital signs as well. So when I say interpret, don't just tell me they're tachycardic. Okay, what does that mean for them? Does that mean that their diastolic time is going to be shortened, so their stroke volume is going to drop? Does their heart rate, is it irregular, so they're losing atrial kick? Interpret what it means. So if they're AFib RVR, they're going to lose 30% stroke volume because of loss of atrial kick. They're going to be losing stroke volume because of a rapid ventricular response. Okay. If they're febrile, okay, they're going to be vasodilated because they have a fever. Their metabolic rate's going to be increased because they have a fever. So that's interpreting, okay, applying all those all that anatomy and physiology to understand why you have the vital signs you have. Maybe it's a surgical patient and you put down, they're tachycardic, so you put down tachycardic, and you're interpreting it as maybe they're hypovolemic from surgery. Okay, so add some more detail in there. The more detail you can add, the better it is. And then I can kind of see how you're thinking. Okay, so that's kind of the 2 hemodynamic ones. So you'll have to interpret the vital signs and then also interpret the hemodynamic numbers. Okay, what does that mean for your patient? Okay, and then come up with your recommended treatment. Why? So if their preload numbers are low and you're saying to give them volume, why would you want to give them volume, right? Because it's going to increase venous return. If your SVR is low and you want to give them a vasoconstrictor, you're going to give them a vasoconstrictor because it's going to cause it's going to cause some vasopressin and increase your cardiac output that way. Okay, so just kind of explain why you're choosing what you're choosing there. And then the cardiac one, that case study kind of goes through a patient that's coding. So you're going to have to kind of look at what the rhythm is for the code, and then kind of explain what you would do for that patient throughout that code. And then looking at your H's and T's. So you need to have 3 of them, what you would treat for that patient, and what H or T is related to. So if you're choosing hypovolemia, how would you treat hypovolemia in a code? If you're choosing a tamponade, how would you treat a tamponade in a code? Okay, so you have to know what your H's and T's are and then how to address them with your coding patient. Okay, and we'll have a look a little bit further at those. And then the last case study is a neuro case study. Okay, and we did a couple of those in class this week. So it'll be a very similar thing. You'll have a kind of a neuro situation. You'll have some vital signs. You'll have an ICP. You'll need to calculate what your CPP is and come up with what you need to do to help your patient. Do you need more blood pressure or do you need less ICP? What medication would you give to that patient and why? Okay, so that's kind of how the case studies are kind of written, and you guys have had some practice at those now, so hopefully it'll be a little bit easier. Okay, there is no rhythm identification. Okay, there are absolutely no rhythms on this test. However, you will be given the description of the rhythm, okay? So it would read something like, you are the nurse caring for a patient with a regular heart rate of 60 and a constant PR interval of 0.28. As the nurse, how do you interpret this rhythm? Okay, so that would be a first degree block because I have a prolonged constant PR interval and a regular rhythm. Okay, so no, you don't have to identify the picture of the rhythm, but you need to know the characteristics of your rhythms. Okay, so another one could be something like your patient has an irregular rhythm with a heart rate of 116. The QRS is normal, and fibrillation waves are noted on the monitor. Okay, so you would need to understand that that patient is in AFib. Okay, so it's going to be more written out for you. So again, you need to know those characteristics, but you don't need to know the actual picture rhythm, okay, for this test. All right, so that's kind of the makeup of the questions, and then this is the breakdown. About 25% of it is looking at respiratory. About 20% is looking at the concepts around ventilation and oxygenation, those kinds of things. And then another 5% is looking at ABG interpretation. Okay, so that's about a quarter of the exam. And then we move down to cardiac is about 20%. Hemodynamics is about 20%. Shock and the different shock states is about 10%. Neuro is about 20%. And then there are some questions on A lines and central lines. Okay, so about 5%. And then I think there's only like one question on delirium. Okay, so that's kind of the breakdown of the questions. Okay. All right, I'm going to make this full screen so I can see it a little bit better. There I am. Okay. All right. So I kind of put some general stuff in here. So, so generally just kind of think about different complications that affect high acuity patients. Okay. So when your patient's coming in, they don't just come in with a ventilation issue. They usually have some other problem that's going on. So think about those patients that may be hypoxic and then develop an arrhythmia because they're hypoxic. Okay, so again, just understanding that they commonly have multiple problems and recognizing the signs and symptoms of those. So this is kind of your basic information. So again, you need to make sure that you're offering nutritional support to your patient. Enteral is preferred because again, that coats the gastric mucosa and it prevents translocation of bacteria out of your bowel. Okay, so that's why an enteral drip feeding is preferred, and you want it to be a high calorie, high protein. Okay, you also want to monitor your blood glucose levels because there's a lot of medications that we give that increase glucose levels. So you want to make sure that those are staying within normal range. We talked a lot about anxiety and pain management when we looked at our ventilated patients. So just make sure that you're providing adequate pain control and sedation so that your patient is comfortable but not paralyzed. Okay. The only time you would paralyze your patient if you had an inverse inspiratory-expiratory ratio, and that does not happen very often. Okay. So you just need your basic sedation and pain medication. Consider impaired communication, delirium, and sleep disturbances. So again, we talked about delirium and inadequate sleep in the ICU. So again, you want to promote early mobility and normalize their night-day patterns. Okay, so that was kind of just covering that basic information. Okay. Any questions on our basic general overview of kind of how you would care for a critically ill patient? Okay, all right. Oops. Okay, So let's talk about arterial lines and central lines. So arterial lines is that blood pressure monitor. It's like a 20 gauge IV catheter, and it goes into the radial artery. Okay, so it gives you a continuous blood pressure reading on your monitor. Okay, central lines, that could be a jugular line or a subclavian line. It just gives you central venous access, and a lot of times you need that for your inotropes or vasoactive medications. Okay, your central lines is also how you monitor your hemodynamics. All right, so arterial lines is blood pressure monitoring, central lines is hemodynamic monitoring. What you're looking for is you're just looking, and this kind of goes a little bit more detail, but basically you're looking for signs and symptoms of infection, phlebitis, or especially a central line and pneumothorax, okay, because you're putting it in either their neck or their chest. So when they're putting it in, they could nick the top of the lung, and you could have a pneumothorax as a complication of a central line being placed. Okay, so you want to make sure that you're checking circulation. So especially an arterial line, you want to check their cap refill on their fingers. You want to check their radial pulse, their ulnar pulse, their palmar pulse. Make sure they don't have any vascular occlusions, anything like that. You want to make sure for your arterial line that your alarms are always on, because if it becomes dislodged, it's in an artery, so it's going to bleed a lot. Okay, so you want to make sure that that is on. And then again, you're doing your assessments for both of these for any signs of infection. Okay. Dressing changes are once every 7 days, unless they're dirty. For a central line, you need that bio patch underneath. You change the dressing every 7 days and the caps every 7 days. Okay. For a central line, your check placement with a chest x-ray. I think that's about it for central lines. Okay. If a patient's short of breath after a central line is placed, again, that's when I would be suspicious of a pneumothorax. Or if you see any changes in work of breathing, O2 sats dropped, anything like that, then you would call the healthcare provider. Okay. And then again, the central line associated bloodstream infections. Okay, that's your CLABC. Okay, putting it in sterile with a mask and a hat on, making sure that you're changing the dressing every 7 days, changing the bio patch every 7 days, or the microbial patch. Bio patch is a brand name. And then changing the caps every 7 days, flushing it with a push start, kind of push pause momentum with a 12 cc syringe is how you flush them. And then again, any blood draws from there, you would want to flush after your blood draw as well. Okay. All right. So that is for central lines and arterial lines. So again, the biggest things are circulation, check for pneumo with a central line, and signs of infection. Okay. All right, so let's move on to our ventilation and our ABGs. Okay, so remember way back when we talked about normal ABGs. So our pH normal is 735 to 745. Our CO2, this is our carbon dioxide. This is work of breathing. It's 35 to 45. PCO2, so this is our partial pressure of oxygen. Do you want to go out? Our partial pressure of oxygen, our normal is 80 to 100. So this is oxygenation. And then our bicarb, this is our buffering system from our kidneys, and our normal is 22 to 26. O2 sats, as long as they're above 93, you're good. So again, this was just pulled from a book. So every books are going to be a little bit different, but typically we go 90 to 93% is a good O2 sat. Okay, so when you're looking at your ABGs, your pH and your CO2, this is work of breathing. So this is ventilation. Your PO2 is oxygenation. So if I have a CO2 and it's high, so maybe my CO2 is like 58 or 60, something like that, I need to increase my respiratory rate to blow off more CO2. If my CO2 is low, maybe it's 30 or 32, something like that, I need to decrease, hypoventilate, so decrease my respiratory rate to retain CO2, okay? And then to improve oxygenation, so maybe my PaO2 is 70 or 50, something really like that, I need to change my PEEP or my FiO2, okay? So PEEP stands for positive end expiratory pressure. It's the amount of pressure at the end of expiration that keeps your alveoli open and stops them from collapsing. Okay, so we all have natural PEEP. We have about 3 centimeters of PEEP all the time. Typically in the ICU, we'll put someone on 5 just because it's a nice number. We like that, but it's typically 3 to 5 centimeters of PEEP. And so what it does is when I exhale, it keeps my alveoli open, okay, for a longer period of time at the end of expiration. And that's how it improves FiO2. Okay, so let's have a look again at that little pig video. So let me bring it up because it's not very long.
Quick question. What does PEEP stand for again? Positive and expiratory.
Yeah, positive end expiratory pressure.
Thank you.
Yeah, sure thing. All right, give me a second here and I'll find that little PEEP video because I think if you have a visual, it'll come back to you of what it is. And it's only like a minute long, something like that. There it is. Okay, so let me share my screen here. So if you remember, these, I believe, are sheep lungs, okay, if I'm not mistaken. This is your ambu bag right here. This is your endotracheal tube. This little tube coming out right here with the blue piece on the end, that's called your pilot tube. This little blue piece is what you inflate with a syringe, and that's how you have the balloon on the end of your endotracheal tube. The bag that he's going to bag with will not have a PEEP valve on it. As they go through, they add PEEP to the bag, and you'll see more recruitment of the alveoli because the alveoli stay open and it allows the air to remain in the alveoli. Okay, so let's just kind of watch it and you'll kind of see.
I want to do this one without PEEP first. Wait, okay, so I just intubated this pig.
I guess it's a pig.
You did a great job. Like that? Very quick. I RSI'd I'm going to bag this up. It won't explode. Sounds like this is called recruitment. See what we're doing here? We're starting to recruit all these alveoli.
So you see the right side, that right lung is inflated really well. However, the left side is not inflating. Okay, and he has no PEEP currently.
And I've got to really bag hard to keep these lungs inflated. Okay.
So when he's talking about bagging hard, that's compliance that we talked about, being really stiff. Okay, so sometimes older people, or if you have a lot of damage to your lungs become very stiff and not very elastic. Okay, so they have poor compliance. So they're very difficult to bag. It takes a lot of pressure squeezing that bag to make them move.
Okay, and then it goes down. that is without PEEP. Okay, so what we want to do is we want to maintain the reason we use PEEP is to maintain recruitment and provide better oxygenation. So I'm going to dial this in with 5, and then I'll show you with 10. TSW. Now see the recruitment difference?
Yep.
Dial it up a little bit more. Okay. That's 15 of PEEP now. So see what a difference this makes for patients
That's insane.
versus.
So what's an adult for that? What should we set that up for an adult?
Start at 5.
So hopefully that helps a little bit when you can see it visually. So as you add more PEEP, it's easier to bag your patient, and the alveoli stay open at the end of expiration. Okay, they don't collapse again. So it helps with alveoli recruitment, and that's how it helps with oxygenation. Okay, so a normal level for PEEP is 3 to 5 centimeters, and you kind of go up. So you would go, 3, 5, 8, 10, 12, 14, or 15. You kind of go up in steps like that. Okay. So that's kind of how PEEP works. All right. Any questions on PEEP? Oh, all right. I'm going to make this bigger again. All right, so that's kind of looking at ventilation. So again, ventilation is work of breathing. Oxygenation is just oxygenating, okay? And you can have 2 types of respiratory failure. You can have hypoxic respiratory failure, which would be an oxygenation problem, or you can have a capnic respiratory failure, which is a work of breathing. It's hypercapnia, right? So CO2. And you can have mixed, you can have both, where you have a ventilation failure and you're hypoxic, okay? So you can have both. You can just have ventilation, or you can have a hypoxic event, okay? So when we're looking at patients with pneumonia, pneumonia would probably be hypoxic and some ventilation as well. It would probably be mixed. If you're looking at something like a PE, that would strictly be a hypoxic event. Okay, that would be hypoxic respiratory failure, because a PE is a blockage of blood flow so that oxygen can't exchange across the membrane of the lung, right, along that capillary membrane. So that's just kind of reviewing your pulmonary stuff. So we talked about respiratory failure and respiratory changes. So level of consciousness, tachycardia, tachypnea, and mild hypertension. These are the early signs of respiratory failure, okay? They're also the early signs of hypoxia, okay? We often have behavioral changes. We're going to become more tachycardic to try and improve our cardiac output so we get more oxygen. We're going to become tachypnic. We're going to breathe faster to try and get more oxygen. And then our blood pressure is going to go up because we're going to be stressed, because we're air hungry, okay? So those are your early signs of respiratory failure. Late signs of respiratory failure, okay, this is where you're now having retractions. So you have sternal retractions. You're cyanotic, maybe around the lips or the nail beds, or maybe your skin is a little bit cyanotic, and you drop your blood pressure. Okay, you become hypotensive now. Okay, so this is late signs of respiratory depression, okay, or respiratory failure. So when I say respiratory depression, it's the same as respiratory failure. Okay, so the terms are the same. Then we talked about another type of therapy you can use for your patients. Instead of intubating them, you can put them on BiPAP, which is a mask. So it's a non-invasive ventilator, okay? And it stands for bilevel positive airway pressure, okay? To go on BiPAP, your patient has to be alert and oriented, okay? And they have to be able to breathe on their own. Okay, so if you had a something in the question that said their Glasgow Coma score was less than 8, or maybe they're obtunded, or maybe their respiratory rate is 4 or less, that would be an indication that they cannot go on BiPAP, okay, because they're not breathing sufficiently on their own and their level of consciousness is impaired. Okay, so again, slow down a little bit and read the question, okay, and really look at the important pieces of information that's been given to you in the question. Because I think some of the questions that are being missed when I go over them, you guys know it. You just didn't read the question, or you read the question the wrong way, or missed one particular word. So just slow down and read the questions. So BiPAP helps with both ventilation, work of breathing, and it helps with oxygenation, because I have 2 pressures. I have an inhalation pressure, or IPAP, that helps with work of breathing, and I have EPAP, my expiratory pressure, and that helps with oxygenation. Okay, so BiPAP is often used with patients with COPD, heart failure, respiratory failure, sleep apnea, those kinds of things. Again, it's contraindicated with altered mental status. And then if a patient has excessive secretions, because they wouldn't be able to expectorate those because they have that mask on. Okay, so that would be also contraindicated. Okay, so that is a non-invasive ventilation, BiPAP, right? Any questions on that? And we'll move on to artificial airways or invasive airways. Okay. All right. So then we kind of talked about invasive ventilation. So this is where you have an artificial airway. So I put a endotracheal tube down their throat. Okay. So indications for suctioning your airway: you don't routinely suction patients, you suction them when they need it. Okay, so when they're coughing, when they have secretions, that's when you're going to suction your patient. Okay, if your patient has a drop in O2 sats, an increase in their respiratory rate, if they have high peak airway pressures on the ventilator, any crackles or rhonchi, that would be your indication for suctioning. Okay, so you have to assess your patient. Okay, some complications that can occur when you're suctioning is you can become hypoxic if you suction for too long a length of time, because when you're suctioning, they're not going to get oxygenation. They can also have bronchospasms when you put the catheter down and suction them. Suctioning increases intracranial pressure. So that's something to watch for with those neuro patients. If you have a patient that has high ICPs, you want to really be careful suctioning them. Okay, and again, make sure it's very short. Dysrhythmias usually is because of the hypoxia. So sometimes, excuse me, sometimes they can have PVCs, runs of VTAC, other dysrhythmias, and typically it's from hypoxia. Okay. They can drop their blood pressure because of a vagal response, okay? If you're suctioning them very aggressively, you can cause damage to the mucosal lining, and you can cause bleeding. It can be painful, and they can also get an infection if you reintroduce the catheter and don't use a sterile technique, okay? All right. So this is just kind of going through some of the care of the patients with an endotracheal tube. So the big one is your VAP bundle. Okay, so we talked a little bit last week about care bundles, and I put a little announcement out there. So VAP bundle is one of the big ones. It's ventilator associated pneumonia. Okay, so you want to make sure that you're doing oral care with chlorhexidine every 2 hours. You want to brush your teeth twice a day. You want to apply a mouth moisturizer. So this is all kind of under your oral care. Okay, they need to be on a proton pump inhibitor. You need to have your SCDs on, and then you need to do a sedation vacation. Okay, and wake them up and do breathing parameters. Can they breathe on their own? Okay, so those are the 4 pieces of that VAP bundle. Okay. And then we've talked about some of the medications that we give for patients. So just looking at some common ones, we talked about giving patients breathing treatments like albuterol, Atrovent, Pulmicort, those kinds of things. We talked about administering broad spectrum antibiotics for those patients that you think may have a pneumonia. Steroids. So steroids are used with pulmonary infections and diseases like ARDS and pneumonia to decrease inflammation. Just be aware of some of the side effects with steroids, especially the hyperglycemia. Okay. And then if you're looking at pulmonary edema, you would want to give that patient some diuretics like Lasix or Bumex. And then if you have someone that is on a ventilator, propofol is a very common sedative that we give our patients. So those are just some of the medications that you may see for those kinds of patients. Okay. All right. So that was pretty much all I was going to go over for respiratory. Again, you have the other study guides for respiratory. If you wanted to pull those out, you can look at the first 3 weeks and kind of look at those study guides and kind of add them to this if you're looking for additional information. Okay. If you have any questions, feel free to email me. I'm free tomorrow and Monday, so we can always set up a one-to-one if you have something specific that you wanted to review. Okay. But if not, we'll keep kind of going with cardiac. All right. So cardiac is about 20% of the test. The first part here is looking at just your cardiac assessment. This part is really important to understand because this is looking at your tissue perfusion, fluid overload, and fluid deficits. So when you're looking at evaluating treatment, so maybe it might be a question like, how would the nurse evaluate blah, blah, blah? Okay. If it's related to a cardiac issue, or you gave a cardiac med, or you're giving a fluid bolus, or anything like that, the way that you evaluate it is you're looking to see what's going on. So I know on the last test, there was something about atropine. You were giving atropine to a patient for a second-degree block. How would you evaluate your treatment? Well, if you're giving atropine for a second-degree block, I'm giving it because I want to increase the heart rate. So I'm going to evaluate it by looking at the heart rate. Okay, so always look to see what the question is asking for, and then look to see how you would evaluate if your therapy worked. Okay, so in general, when you're looking at tissue perfusion, we talked about looking at urine output because my kidneys are very sensitive to blood flow. Okay, so if my kidneys do not get adequate perfusion, they don't get adequate blood flow coming out of the heart, they're going to stop making pee. Okay, so this is a really great indicator of good tissue perfusion. The other one is looking at the quality of your pulses. Are they thready? Are they bounding? Do you have distal pulses? What about the color of your skin, the warmth, the cap refill? Okay, so those are all looking at tissue perfusion. Okay, organ tissue perfusion. Altered level of consciousness is another one, right? If I don't have enough tissue perfusion, I'm going to become confused, right? So again, think about your end organ perfusion. And then these two are looking specifically at fluids. So how would you evaluate a patient for fluid overload? Maybe they have peripheral edema, jugular vein distension, maybe crackles, their weight may be up, looking at their eyes and nose, those kinds of things. Those are things that I would do to evaluate fluid overload. And then looking at fluid deficit, I'm going to do kind of the opposite. I'm going to look at their skin turgor, their mucous membranes, again, urine output, their eyes and nose, and their weight. Okay, so that's just looking at some evaluations of care for patients. Okay, any questions with that? All right, the next part just goes over blood administration. And I'm not sure, you should have done this in lab, but because everything's kind of all over the place right now, typically this is done in lab or in clinical. So I threw it in there just because we haven't really talked about blood administration, but I want to make sure that you understand the process of doing a type and cross and administering blood products to a patient. Okay, so if you're administering any type of blood products, whether it be packed red blood cells, whole blood, fresh frozen plasma, cryoprecipitate, platelets, anything like that, okay, you do have to have 2 RN signatures, okay, on the tag. So it has to be 2 registered nurses that are verifying the blood product. You have to double check the patient's name, their ID number, and the blood type. Okay, so typically these are all scanned. So you scan the patient, and then there's 3 things on the bag of product that you scan, and it has the number, the blood type, and the association with the patient. Okay, you want to get a baseline set of vital signs. So before you even start the blood, you want to know what their blood pressure is, temperature, respiratory rate, heart rate. So a full set of vital signs is a baseline. You're going to use normal saline to prime your tubing, okay? And then you can, once all these are done and you have a consent that is signed, then you can go ahead and hang your blood, okay? You want to stay with the patient for the first 15 minutes and make sure that they don't have a blood reaction. Okay, so typically you either take the blood pressure machine in there with you, or if you're in the ICU, you have one on the wall. And typically I would go ahead and set my vital signs for every 5 minutes. Okay, and just kind of hang around and do all your documentation that you need to do. By the time you do all your documentation, 15 minutes is kind of up. Okay, and then after that first 15 minutes, then it would go to hourly. Okay, you have 4 hours to transfuse blood products. Okay, after 4 hours, if they don't go in, you have to take them down and send them back to the blood bank. Okay, FFP goes in pretty fast. Cryo goes in pretty fast. I mean, those I can put in like 10, 15 minutes. They go in really quickly. If it's a larger volume of fluid, so something like packed cells or whole blood, those typically take a little bit longer, an hour to 2 hours, something like that. On the bag, blood bag itself, it will tell you the volume that's in the bag. Packed cells is usually about 275 cc's. FFP will be different with every bag. So make sure that you're looking at your bag when you're scanning them, and then put that volume in your INO. Okay. I added some information here about Jehovah's Witness. So as you know, a lot of Jehovah's Witnesses will refuse blood products. However, they will take Procrit, which helps to stimulate the production of red blood cells. Okay, so there are some options that you can offer them. Okay, any questions on blood administration? I don't think I have any questions on blood administration, but we haven't covered it in class, and I don't know if it's being covered anywhere in clinical, but guaranteed you will have an NCLEX test or an NCLEX question on blood administration. So I wanted to make sure that I included it somewhere so you guys have some information on it. Okay. All right. And then the next part I put in here was a little bit more detailed information about your cardiac meds. So we talked about beta blockers. So beta blockers slow rhythms down, right? It's a blocker. So if I had a patient that already had a slow heart rate, wouldn't want to give them a beta blocker. I'd want to hold it and contact the physician. If I had a patient in a block of some kind, first degree that's really slow, a second degree type 1, a second degree type 2, or a third degree, again, critically thinking, probably wouldn't want to give them an additional blocker. So I would want to hold it and contact the physician. Okay, so really start using that critical thinking about medications that may be in your question about, what your next step would be. Okay, so metoprolol, timolol, anything with the "all" at the end, those are your beta blockers. Okay, calcium channel blockers, the common one that you see is cardizem or diltiazem. So again, a lot of times these are given for heart rhythms. Cardizem is often given for hypertension as well. Okay, so I put kind of the uses in here. All right. Dysrhythmics, we talked about dysrhythmics. So amiodarone is your dysrhythmic that you give for a flutter. You can give it for atrial fibrillation. You can give it for SVT. You can give it for VTAC. And then it's the antiarrhythmic that we give in a code as well. Okay, so amiodarone is a big one that we give for patients. It does cause hypotension. So if you're giving it in practice, just be careful, especially with the bolus dose, because you will bottom your patient out. And then we talked about adenosine is another dysrhythmic. Adenosine will only work on regular rhythms. So we give it for SVT and we can also give it for VTAC. Okay, so again, it's going to slow conduction down. All right. So all these are kind of slowing things down. All right. And then we talked about ACE inhibitors. So these are all your prils, captopril, lisinopril. Okay, so that they're in the ill family of ACE inhibitors. And again, this is typically for hypertension. And this is where it converts your angiotensin 1 to angiotensin 2, and this occurs in your lungs. Okay, so you just have to be kind of careful a little bit. The one big thing with any ACE inhibitor is angioedema. Okay, that is a huge complication with any ACE inhibitor. It's a great test question. It won't be on mine, but it's a great one for the NCLEX to remember. ACE inhibitors can cause angioedema, and that would need to be immediately reported because you're going to lose your airway pretty quickly. Okay. And then I kind of put some of the other medications in here. So we talked about vasopressors. So maybe my SVR is low, and my blood pressure is low. I've already filled my tank. I've got good preload, but now I need to compress the vessels. So I want to add a vasoconstrictor. So a common one is Levophed or norepinephrine. Okay. If I have maybe a patient that is in heart failure, maybe their SVR is very high, and I want to bring that down and offload the heart, I can give them a vasodilator like nipride or nitroglycerin or cardine, something like that. Okay, those are vasodilators. Anticoagulants. So heparin we give for DVTs and we give it for a PE. We also give heparin to a patient that's having an MI, okay, to make sure that their blood stays nice and thin and doesn't clot in their coronary vessels. We also give heparin to AFib patients as a prophylactic, right? These are all prophylactic uses of heparin to prevent complications. Okay, so it helps thins out the blood. All right. If you give too much heparin or you want to reverse heparin, you can always give protamine. So it's a really nice drug to give. So a lot of our cardiac patients, they come in and you bolus them with heparin and then they want to go to cath lab and you're like, oh my gosh, they've had like 5,000 units of heparin. It's easy to reverse it quickly. So it's a really nice drug to give. So remember, heparin is given for your MI patients and your AFib patients to thin out their blood and prevent complications. Okay. Coumadin, this is more of a long-term anticoagulant, okay? So with this one, if you overdosed or needed a reversal for this one, you're looking at vitamin K, Okay, so it acts at a different part in the clotting cascade. You want to monitor your PT and INR. Okay, for heparin, it's either your 10A or your PTT, depending on what facility you're at. And then other ones I added in here, again, your Lasix, your steroids. Okay, so that's just kind of looking at some of the medications, because you don't have to know the specifics of the medications, but you need to know what they do or what you're giving them for. And it's because there may be a question that says your patient is receiving heparin. Okay, why would you give heparin to a patient with an MI? Okay, what is the indication? Okay, something like that. All right, so those are kind of the ones to kind of look for. All right. That's looking at cardiac meds. And then the next part is going over the rhythms again. This is exactly the same as what we had on the prior study guides. So I'm going to go through them very quickly and not in much detail. Okay. So sinus brady is less than 60. I have normal waveform patterns and normal intervals. Okay. My PR interval is normally less than 0.20. My QRS is normally less than 0.12, and my QT is normally less than 0.44. Okay, so sinus bradycardia, regular rhythm, it's just less than 60. I'm going to treat symptomatic bradycardia with atropine, dopamine, epinephrine, and pacing. Sinus tachycardia is a regular rhythm. I have regular waveforms. My heart rate is greater than 100, but less than 180. Okay, you will not have sinus tach in the 200s. Okay. Sinus tachycardia is usually a physiological response to something. So to correct sinus tachycardia, you treat the cause. If it's anxiety, pain, fluids, fever, whatever the cause of the sinus tachycardia is, that's how you would treat that patient. And then we talked about some atrial rhythms. So PACs is just a early beat that comes from somewhere in the atria outside of the SA node. Okay, and that is a PAC. SVT is super fast. So this one is always regular. You do not see P waves because it's too fast. And the rate is usually 180s to 250. Okay, so anything that's super, super fast. Your patients will become symptomatic because they won't be able to tolerate that faster rate for that long time. So a lot of times they have palpitations, they have shortness of breath, those kinds of things. They'll be hypotensive. So for this one.
I have a question on sinus tach. Would you ever give any medications to slow that down or just treat the cause?
Treat the cause.
Okay.
Yep.
Thank you.
Sure. So for SVT, you can try vagal. You can try adenosine or amiodarone, or you can try cardioversion. Cardioversion is electricity that slows rhythms down. Okay. And that is SVT. Atrial flutter. You're looking for shark tooth waveforms in between your QRSs. Okay, flutter waves. Your pattern can be regular or irregular. Okay. And then for this one, you're going to treat it with beta blockers, calcium channel blockers, antiarrhythmics, and anticoagulants to prevent complications. If it's a very fast rhythm, you can do cardioversion if you need to slow it down. When you're looking at atrial flutter and atrial fibrillation, your atrial rate will always be faster than your ventricular rate. Because in here, I've got 1, 2, 3, 4 flutter waves for every QRS. Okay, so I've got 1, 2, 3, 4, 5, 6 QRSs. And if I have 4 flutter waves for every QRS, that means I have 24 flutter waves. Okay, so your rate will always be faster in your atrial rhythms. Okay, atrial fibrillation is always irregular. You will have fibrillation waves. Okay, treatment is the same. Calcium channel blockers, beta blockers, antiarrhythmics, and anticoagulants. Okay. All atrial rhythms, whether that be PACs, SVT, flutter, fibrillation, they will always have a normal QRS. The only time you have an abnormal QRS is with ventricular rhythms. All other rhythms have a normal QRS. Okay. And then these are your blocks. So again, I've got first degree. So at first glance, first degree is looks very similar to sinus rhythm or sinus Brady. So it's always a regular rhythm, but I just have a longer PR interval. It's greater than 0.20, and that's the only difference. Okay, I have a prolonged, constant PR interval. So for first degree block, I don't need to do anything. Okay. Second degree type 1 is always irregular, and I have a prolonging PR interval. So I've got a PR interval here. I've got a P wave with no QRS after it. I've got a P and a P and C. It gets longer. My PR interval is getting longer. So I have a progressively lengthening PR interval, and I have a randomly dropped QRS, but I only drop one. Okay. For this one, because I only drop one QRS, this one is monitor as well. Okay. Second degree type 2, this is the one you become concerned about. My PR interval stays the same, but I have randomly dropped QRSs, and I have more than one. And that's why you're concerned about this one, because I have more than one, whereas this one I only ever have one. Okay, so this one I treat the same as a bradycardia: atropine, dopamine, epinephrine, pacing. Okay, so again, if you had a patient and it was described, your patient has a second degree type 2 block, and you gave atropine, right, for your patient, how would you evaluate your treatment? Well, I would look at the rate, right, and see if my rate got better, because it should hopefully speed it up. And then third degree is always regular, but you've got more P waves than QRSs. Okay, so you'll have a QRS and then a P and a P and a P, QRS, P, P, P. So you'll have a lot more P waves in there than QRSs. Okay, so this one is an emergency. Okay, you wouldn't want to give any additional fluids to a patient in third degree block because their heart is already stressed. So if you think about it, their atria are contracting and their ventricles are contracting, but they're not pushing blood forward at the same time. They're out of synchrony with each other. Okay, so your cardiac output is already greatly impaired. Okay, if you gave them fluid, you'd push them into heart failure. Okay, and fluid overload, and they wouldn't be able to manage. So for these patients, again, you want to control the rate by either probably a pacer, but dopamine, atropine, epinephrine, but typically they need pacing. Okay, so that's quick down and dirty on blocks. Okay, so any questions on sinus, atrial, or blocks?
Just for my amusement, second degree type 2.
Yep.
What's your experience with type 2s? Do you see the QRS normally narrow or is it wide?
Narrow.
You see narrow? Okay.
Mm-hmm. Yeah.
Must be a pre-hospital thing then. Okay.
Yeah. All right. So let's look at our ventricular rhythms. So remember, all ventricular rhythms are wide and weird. Okay. So we're looking at the QRS because the QRS is looking at ventricular contractions. So if I have a premature ventricular contraction, okay, wide and weird, and it's looking at contraction coming from the ventricles. Okay. If I have every other as a PVC, we call that bigeminy. Every third, trigeminy. If I have 2 PVCs in a row, it's called a couplet. Okay. Once I have 3 PVCs in a row, now we're looking at VTAC. Okay. So for PVCs, we usually don't treat them. It's usually related, again, to some stimulant or something like that. So this is looking at VTAC. So this is like a monomorphic VTAC. So mountains or mono, okay, means the same. So again, it's that really wide ventricular rhythm, okay? This bottom one would be more polymorphic because it changes, okay? And it gets big and then a little smaller, big and a little smaller. And then this one is a type of VTAC called torsades, where you have peaks going up and then really low down. So you almost have like a ribboning or a tornado kind of a waveform, okay? So for VTAC, you can have a pulse, or it could be one of your lethal rhythms with no pulse. So that's the first thing that you want to check. Does my patient have a pulse? Okay. You can give them an antiarrhythmic like amiodarone or adenosine, or you can cardiovert them. Okay. If they have no pulse, they're dead. So you want to start CPR, and VTAC is a shockable rhythm. Okay, so you can defibrillate them. If they have this particular rhythm, you can also give them magnesium at any time, okay, for torsades. All right. And then ventricular fibrillation, this patient is dead, always dead, okay? So basically it's just fibrillation waves on the monitor, okay? There's no QRSs, there's no P waves, it's just shaky, 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 okay? So this one, immediate CPR, you want to shock, and then your first drug for any code is going to be epinephrine. Okay. Asystole is just a flat line. Okay. So asystole, again, this is a lethal rhythm. Your patient is dead. Okay. They require immediate CPR. I can't shock asystole though, because there is no electrical activity. So I can only give them CPR and epi. All right. Any questions on those before we talk about PEA? All right. So let's look at PEA, because this is one that you probably should know very well. Okay. So PEA on the monitor, you will have electrical activity of some kind, but there's no pulse. Okay, so it may say something like your patient is in sinus rhythm on the monitor, but they have agonal respirations and no pulse. Okay, that patient's dead. Or it could be your patient is on the cardiac monitor, which shows sinus bradycardia with their apneic and no pulse. They're dead. Okay, so if they have an electrical rhythm, but it's telling you in the question that they're apneic or agonal, or that they have no pulse, that person is clinically dead, okay? And they're in a code situation. So that's kind of what you see for PEA. It's one of the most common dysrhythmias that you do see after defibrillation. So a lot of times when you're running a code, it may be you shock your patient, you get a rhythm back, but there is no heartbeat back, okay? So prognosis is pretty poor unless you figure out why your patient coded, okay? So that's when we look at our H's and T's, all right? So if you have a patient in PEA, you immediately want to start CPR, and you can give epinephrine every 3 minutes, okay? And then this is basically kind of what you have to go through, okay? So look at the question and figure out, could my patient be hypovolemic? If they could be, I'm going to give them a fluid bolus. Could they be hypoxic? If they could be, I'm going to oxygenate them with 100% oxygen. Could they have a high potassium? Well, I can reverse it with calcium or insulin D50 or bicarb? Could they have a low potassium? Well, maybe if they could, I'd give them some potassium. Could they be acidotic? Okay, hydrogen ions. If they are, I'm going to intubate them or bag them, ventilate them better. Could my patient be cold? Now I'm going to warm them up. Okay. Could my patient have a tension pneumo? Okay, so I'm going to do a needle decompression. Could my patient have a tamponade, a cardiac tamponade? Okay, if they could, then again, I'm going to hand a needle to the physician and do a pericardial centesis. Needle the chest, that would be fine too. Okay, but needle the chest. Have a thrombosis, either a coronary thrombosis. Maybe the story said they came in with chest pain, and I would suspect a coronary thrombosis. And I need to give them anticoagulants and get them to cath lab. Maybe the story said that they were profoundly hypoxic. And so I'm thinking, maybe they have a PE. So again, I can give them thrombolytics. Okay. Or maybe the story said they were found down unconscious. And you're thinking maybe they're an overdose, the toxin. So I could give them some Narcan. Okay, so that's kind of how you work through those H's and T's. Okay, so it's really important that you understand how you would identify that rhythm. Okay, what you're immediately going to do. So your immediate response is CPR and epi. Okay, and then you have to figure out why your patient coded. Okay, you need to look at the question and apply these to the question. So if you're thinking they're hypovolemic, give your fluid bolus. So you need to know your H and T and your treatment. Okay. Any questions on this? I think I went over it again on the prior week video as well. Okay. All right. So this is just looking at differentiating cardioversion from defibrillation, and we kind of talked about that before. So cardioversion slows rhythms down. Defibrillation is what you're doing for dead rhythms. The only dead rhythms you can defibrillate is VFib and pulseless VTach. Okay. This kind of looks at what you would do for a patient that's having an arrhythmia. So again, dysrhythmias and arrhythmias, it's the same thing. Okay, it just means an abnormal rhythm. Okay, so don't get hung up on the lingo. So again, I want to assess my ABCs. Are they breathing on their own? Do they have a patent airway? Do they have a pulse? Okay, put them on a monitor, get them some oxygen, get your vital signs, get a 12 lead. Okay, all those kinds of things. Get your IV, your labs. So if you had a patient and they're having an arrhythmia, some of the labs that you might want to look at are your troponins, that's your cardiac enzymes, your CKMBs, your CBC, your electrolytes, make sure that their potassium is okay. Okay. Other things you might want to consider is a PT and INR. If they are on a blood thinner of some kind, you could assess their coagulation as well. So those are just things to kind of keep in mind. Okay. All right, everyone's favorite, hemodynamics. Any other questions on the cardiac piece before we move on to hemodynamics? All right. And hemodynamics, again, I'm not going to go into it as much detail because last week, like literally the video was an hour and a half, I think. And that's still available. Let's look at some of our definitions and kind of what we're looking at. So when we're looking at cardiac output is a calculation. It's heart rate times stroke volume. And what it means is it means global tissue perfusion. Cardiac output is the amount of blood pumped out of the heart, and it delivers oxygen and nutrients to the rest of our body. Okay, so cardiac output is tissue perfusion. When we're looking at stroke volume, one of the components of cardiac output, stroke volume is made up of preload, afterload, and contractility. Okay, So if I'm looking at a patient and I need to improve their cardiac output, I need to either improve their heart rate or improve one component, at least, of their stroke volume, okay? Because that's how the calculation is. So I need to either improve heart rate or stroke volume. So let's kind of look to see how we do that. So preload is pressure. So again, if you think of pressures, those are all your preload numbers. And this is actually volume. It's the amount of volume that's returning to the heart, okay? And we have a few of them. So CVP, central venous pressure, this is measured in the right atria, okay? So it looks at blood returning to the heart from the inferior and superior vena cava, okay? And your normal is about 0 to 5, 0 to 6, something like that, okay? That is central venous pressure, CVP, okay? Preload, PP. And then you have your pulmonary artery pressure. So again, it's measuring the volume in your pulmonary artery on its way to the left side or to the lungs, okay? So it's also a preload number. And then you have your pulmonary artery wedge pressure. So this is further down the pulmonary artery, and it looks forward into the left side of the heart. So it's actually measuring left-sided preload from the left atria, but it doesn't actually go into the left atria, okay? Because blood goes from the pulmonary artery into the lungs, gets oxygenated, and then comes back into the left atria through the pulmonary vein. Okay, so basically this catheter just looks forward, okay, to that left side, okay, but these are all your preload numbers, all right? And think of your preload as volume. So if I need to improve my cardiac output, heart rate is the easiest one to fix, either speed it up or slow it down, and we talked about how to do that with beta blockers, calcium channel blockers, inotropes, atropine, things like that, okay? And when you're looking at stroke volume, I put them in a specific order for what you want to fix first. You want to fix your preload first, then your afterload, and then your contractility, okay? So you always want to fill your tank, okay? And then do your vasoconstrictors. And then contractility is putting your foot down on the gas, making your heart work harder. Okay, so that's kind of the order you want to do them in. So you always want to fill your tank first. So if your numbers for your preload are low, you want to give them a fluid bolus or blood products or colloids, okay? Something that's going to increase your circulating volume, all right? If your preload numbers are high and your heart can't handle that, and you want to offload the heart, maybe you have a cardiac patient and they're in cardiogenic shock, something like that, and you want to give them diuretics like Lasix or Bumix, or vasodilators like nitrocardine, nipride, okay? So those are all your vasodilators, okay? So if it's a preload problem and it's low, you want to fix it with fluids. If it's a preload problem and they're high, you want to fix it with diuretics and vasodilators. Okay. And then afterload. So if you think about the heart, right, the heart ejects blood out of the top through the aorta, right? So that pressure that it has to eject blood out of, that's your diastolic pressure, and that's your afterload. And we call it SVR, systemic vascular resistance. So if you think of after, it's got the and the okay? So afterload, okay? So your normal is 800 to about 1400. And if it is too high, you would want to give a vasodilator to decrease your afterload. If your afterload is too low, and you want some more squeeze, you would add your vasopressors, okay? So these are some of those examples. I only did a few. There's a lot more on last week's video. I think I had like 7 or 8, okay? I only put a couple on here. So again, when you're looking at interpretation and treatment, So again, this is a post-op surgical patient. So I know they're surgical, so I know they're going to be dry. Their heart rate's 120. So they're tachycardic in response to something, right? Sinus tachycardia is a compensatory mechanism to respond to something. I'm trying to increase my cardiac output, right? Because it's heart rate times stroke volume. Well, if my stroke volume's not there, I can't fix that. I'm going to increase my heart rate. Okay, and that's your fight or flight system, your sympathetic, parasympathetic. It's how we compensate. Unfortunately, when my heart beats faster, my diastolic filling time shorter. Okay, and so that does drop my stroke volume. Okay, my blood pressure is 88/56. So if I'm looking at my blood pressure, I don't have adequate tissue perfusion. Okay, that's interpreting my blood pressure. Don't just say hypotensive. Okay, what does that mean? It means that my organs are not getting good tissue perfusion. Respiratory rate is normal, SATs are normal. Okay, so if I'm looking at interpretation, I'm tachycardic, which is a normal compensatory response. My blood pressure and my MAP are low, which means I have impaired tissue perfusion. Okay, so then I look at my hemodynamics. My cardiac output is low, it's less than 4. My index is low, it's less than 2.5. My CVP is okay, but my PA pressures are low. Okay, so my left side is low, and my SVR is okay. So if I'm looking at this, my PA pressures are low, that's a preload number. The right side is okay though, so it's the left side that's low, and I have low tissue perfusion. So based upon these numbers and based upon this being a surgical patient, I say this patient's dehydrated because their PA pressures are low, their tissue perfusion is low, and their blood pressure and MAP kind of match, right? So this person needs fluids, all right? Any questions on how you kind of look and read and kind of go through your vital signs and your hemodynamics and kind of match them together? So this is where that critical thinking and your A and P kind of come into play. And you have to critically think, what am I going to do with this patient? Okay. And this is truly how we manage patients in the ICU. All right. So we'll look at the next one. So this one, you're caring for a cardiac patient. All right. So I know it's a cardiac patient. So I know they will not have a good pump. All right. Because they are a cardiac patient. They have the following hemodynamics. Their heart rate is 60, which is low. Their blood pressure systolic is 80, which is low, and their MAP is 50, which is low. So they're bradycardic with impaired tissue perfusion. Their cardiac output and index are very low, so confirming impaired tissue perfusion. And their CVP is high, and their wedge pressure is high. Okay, so if you remember, we talked about the Starling's law. Okay, the higher the volume, the harder the heart has to work, right? To pump that volume forward. Well, if this is a cardiac patient, the heart probably can't work that hard. Okay, so if I'm looking at this patient, my preload numbers are actually high. Okay, but I don't have a very good heart rate. So for this patient, I would probably want to add an inotrope like epinephrine to help with contractility to be able to push this fluid forward. The other thing you could consider as well is a diuretic to offload the heart, but you would still need some kind of help with contractility because my tissue perfusion is still low. So before I diurese this patient, I'd want to get my tissue perfusion up. So I'd want my systolic above 90 before I diurese them. Does that kind of make sense? Meh. So for number 2, if I'm looking at it, it's a cardiac patient, so they have a poor pump and they're fluid overloaded. Okay, but they're hypotensive. If I just gave them straight diuretics to offload them, I wouldn't fix my perfusion problem. Okay. My blood pressure would still be low. My cardiac output, my index would still be low. My heart wouldn't have to work as hard, but it would still be low. So this patient needs some help. They need some pump help. So I can give them an inotrope. I could put them on a balloon pump. They're not that bad for a balloon pump, though, with a heart rate of 60. And yes, I do want to offload these numbers. I don't want them to get fluid overloaded, especially a cardiac patient, but I can't diurese them until I get their tissue perfusion under control. And the way I do that is by controlling the heart pump itself with an inotrope. Okay. All right, let's look at the next one. So this one is a pretty straightforward one. Heart rate of 112. So again, it's tachycardic. So it's compensating. I'm very hypertensive, 210/98. Respiratory and SATs are fine. My cardiac output is a little bit low and my index is a little bit low. Again, my preload numbers are high. My CVP is 14, my wedge pressure is 16, and my SVR is very high. So that's my afterload. So on this one, I have a preload problem and an afterload problem. My heart rate's okay. So when I'm looking at this one, I would probably want to give them a diuretic or vasodilators. Okay, so your vasodilators will help both decrease your preload and decrease your afterload numbers, right? Because if I vasodilate somebody, the blood's going to stay in the periphery. Okay, so when you're thinking about hemodynamics, the first thing to do is know what your normals are, so you know what's not normal. Okay, cardiac output and cardiac index are tissue perfusion. CVP and wedge pressure and PA pressures are preload numbers. SVR is an afterload number. You want to correct your preload numbers and correct your SVR numbers and then correct your contractility. Okay. Look at the story. If it's a cardiac patient, you know they have a bad pump. You know they're going to have impaired contractility. If it's a surgical patient, you know they're going to be dry. Okay, so kind of look at the question. This last one, you know, they were in hypertensive crisis. Okay, so I know their SVR is going to be high. Okay, so kind of look at your question and kind of interpret them from there. All right. The next little part right here is looking at a balloon pump, the care of a patient with a balloon pump. So this would be a patient that would be in cardiogenic shock. And this one, when the balloon inflates during diastole, it pushes blood forward up the aorta to fill the coronary arteries. When the balloon deflates during systole, it pulls blood back and offloads the pump of the heart. Okay, so that's basically what a balloon pump does. Okay, the biggest thing with balloon pumps is you want to make sure that you're checking the neurovascular status. So again, circulation is a big thing, especially distal pulses to their feet and the left radial pulse. Okay, those are the ones that you want to check. And then you want to make sure that they're making enough urine output. Because if the balloon is too low in the aorta, it will block the renal arteries. Okay, and they won't get blood supply. So all right. We will move on. All right. So before we start shock, any other questions on hemodynamics? Again, there's a lot of other examples in last week's video because it was quite long. So I would suggest kind of have a look at that. If you want to go over them one-on-one together, again, shoot me an email. I'm more than happy to do that. I've got time tomorrow and Monday and Tuesday morning, a little bit of time before class. Okay. All right, so let's look at shock. So we talked about a few different kinds of shock. So we talked about septic shock if a patient has some kind of an infection. We talked about cardiogenic shock if they have some impaired cardiac function. Hypovolemic shock if they have maybe a burn or a massive fluid loss due to a trauma, something like that. And then we looked at neurogenic shock. So neurogenic shock, that's your head injury, your spine injury patient, and the difference between that one is your bradycardia. Okay. And so then again, I just kind of split them out. So hypovolemic shock, you want to replace your fluids. So you need IV access, and then assess for fluid loss. Okay. You may need to give blood products. And again, any type of shock, you're going to start with those ABCs. Okay. For septic shock, this is a known or suspected infection and 2 SIRS criteria. So you guys remember your SIRS criteria is increased heart rate, systolic less than 90, increased respiratory rate or CO2, and increased white cell count or a low white count. Okay, so have a look at those. And then for this one, again, you're starting with your ABCs. You want to do your blood draw, get your, they're like laughing out there, get your cultures drawn, your lactic drawn, get your antibiotics given within the first hour, and then do your fluid resuscitation. If your lactic is still greater than 4, you can repeat your fluids. And then if your systolic is less than 90, start your vasoconstrictors. In last week's review, there was the sepsis bundle with a little picture of the man in the bed. So again, have a look at, I didn't include everything because this would be like 50 pages long. So use your guides from the previous weeks as well to study. Okay. So if you're evaluating your fluid resuscitation for your hypovolemic or your septic shock patient, this is how you're going to do it. You're going to look at urine output. You want urine output at 0.5 milliliters per kilo per hour. You want a MAP greater than 65. You want a cardiac output greater than 4, stable vital signs, and then stable assessment. Okay. We talked about multiple organ dysfunction. Okay, so this is when you have 2 or more organs that are failing. So a lot of times this happens in shock, where you may have respiratory compromise and a cardiac compromise or renal compromise, and then you have multi-organ system failure. All right. For neuro, we kind of talked about all of this last week on last week's video. So this is kind of looking at the same thing, looking at your Glasgow Coma Scale and looking whether you have severe, moderate, or mild injury. Looking at the skull as a box, and you've got your brain tissue, your CSF, and your blood. Okay. Then doing your assessment. Okay. Cushing's triad we've talked about. It is a medical emergency. Okay, so be really aware of the signs and symptoms of Cushing's triad. When you're looking at ICP, altered level of consciousness is your most sensitive indicator, and your normal ICP should be less than 15. Okay. Here's your GCS right here. And then you will need to know how to calculate your cerebral perfusion pressure. Okay, so it's your MAP minus your ICP. Okay, and it should be greater than 60. Okay, so again, I would have to, there's going to be like a case study on this. So again, it'll be a little scenario. Your patient was admitted with a closed head injury. Their ICPs are elevated at 22. Here's your blood pressure. Now calculate your CPP and interpret it. Is it adequate? What's your treatment going to be? Is your treatment going to be to decrease the ICPs? Okay, and we can do that with mannitol. Or is your treatment to increase the blood pressure with vasoconstrictors? Oops. we kind of talked all about those last week. These are your medications. So again, mannitol, hypertonic saline. These are some of the nursing functions that you can do to decrease intracranial pressure. So making sure that their body's in a good alignment. You don't have tight collars or trach ties, those kinds of things. Okay. And then we talked about last week complications of high ICP. Okay. So complications would be inadequate cerebral perfusion, which leads to herniation. Other things can happen is pressure on the pituitary gland, which can stimulate the inappropriate secretion of antidiuretic hormone. They can go into SIADH, or they can go into diabetes insipidus as well. And then the last part we talked about was spine. And we talked about autonomic dysreflexia. So again, this is related to typically a full bladder or full bowel, typically the rectal vault. It could be tight clothing, but I've not really seen it to be tight clothing. It's usually bladder or bowel. And basically your patient gets very flush, they get a headache, they drop their heart rate, and you have to release the pressure or evacuate the bowel or the bladder, okay, to get the symptoms to go away. Kind of talked about rehab for patients with the spinal cord injury. So just kind of remember Maslow's hierarchy of needs. Physiological comes first, and then kind of everything else comes after that. And then these were your neuromedications. So we talked about mannitol being an osmotic diuretic. And then methylprednisone is your steroid, which is used in spine injuries to decrease swelling around the spinal cord. Okay. So that is it. So again, I didn't include everything that on the previous study guide. So again, I would suggest you watch last week's video and look at that study guide as well and kind of combine them together, and you guys are going to do great. All right. Any questions? It's a lot of information, right? So it's going to be on respiratory, ABGs, cardiac, hemodynamic, shock, and neuro. Okay, so those are the pieces that you need to kind of review. All right. And again, there's no rhythms, but they are going to be a scenario type questions. So you would need to understand what the rhythm is. I think you guys are going to do a great job. You guys did a great job on the last quizzes. So, all right, I'm going to stop recording